Welcome to the Drive to ViVE webinar powered by Chime and Health. We're so glad that you're here as we all head into our holiday break. I'm Sandy Vance, the head of AI at Health, leading the data innovation zones at both Health and ViVE. And I'm here today to lead this Drive to ViVE LinkedIn Live series. Our goal with this series is really to guide you on the road to success as we chart the course before welcoming you all in Los Angeles, February 22 to 25, 2026 for ViVE 2026. Each month, these conversations with our partners will feature influential leaders in the healthcare sector discussing key topics impacting digital health and health IT right now, including revenue cycle management, interoperability, cybersecurity, and today we'll discuss artificial intelligence with some key thought leaders. As AI continues to transform healthcare delivery, a critical challenge remains. How do we ensure that access to AI innovation across diverse care settings, particularly those struggling with resource limitations? This panel brings together leaders across healthcare to explore strategies for responsible AI implementation across community health centers, rural health systems, and health plans. These panelists will provide a roadmap for healthcare organizations navigating the complexities of AI adoption when facing constraints in funding, staffing, and technical capacity. I'm really looking forward to this conversation today and engaging with our speakers and all of you out there in LinkedIn land. We'll use the comment section to take as many questions as we can, so please feel free to enter those throughout the discussion, and then when we get to the end, we'll do our best to answer them all. Today, I'm joined by this fabulous panel of three well-known CEOs in the area of health AI. We have Dr. Brian Anderson, who's the CEO of the Coalition for Health AI, Sachin Jain, who's the president and CEO of Scan Health Plan, and Q Ree, who's the CEO and president of NAC. I'm going to have each of them start off with a brief introduction to them and their organization. So let's start with you, Dr. Anderson.
Great. Well, first off, Sandy, thanks for inviting me and for this wonderful group to share a little bit of our thoughts on AI. So what is CHAI? So Coalition for Health AI, or CHAI, is a nonprofit group that started work in the middle of the pandemic. It was during that time when so many of us were coming together in a public-private partnership, solving a lot of the issues associated with the pandemic, that we began asking questions around AI. And the real animating question that started CHAI was a question around building consensus at a technically specific level around what good, responsible AI in healthcare looks like. We quickly realized when we asked that question that we don't have consensus, that we don't have a common definition of what good looks like. And I think we would all agree, the listeners would agree, that in a consequential space like health, it's a good thing to have a common definition about what responsible AI in healthcare looks like. And so we started with 8 orgs. We now have over 3,000 organizations, both from the private sector and public sector. And we are building those industry standards for responsible AI throughout healthcare use cases.
Fantastic. Sachin?
Yeah, good afternoon, everyone. It's a great honor to be with you all today. SCAN is not a radiology company. We are actually originally founded as the Senior Care Action Network in 1977 by a group of community activists we affectionately call the 12 Angry Seniors. These were people who wanted to change the face of aging in Long Beach, California. Today, more than 48 years later, SCAN is a Medicare Advantage plan that serves over 400,000 seniors in California, Arizona, Nevada, New Mexico, Texas, and now Washington State. We also operate 4 different clinical divisions: Healthcare in Action, which is a medical group for people experiencing homelessness. We also have Welcome Health, which is our primary care medical group, My Place Health, which is our PACE entity, and then finally, we have home-based medical that does annual wellness visits, chronic disease management, and palliative care for older adults. I would say we are in the first of a 9-inning journey to really implement artificial intelligence in our company, and I'm excited to share some of what we've learned in that early inning. So turn it over to Q.
Thank you so much. Thanks for having me, and I'm grateful to be on this amazing panel. So I am Q Ree, and I'm representing the National Association of Community Health Centers. So I'm at my core, primary care doc and internist and pediatrician who worked in community health centers, but have also had the privilege in working in the public and the private sector prior to this role nearly 2.5 years ago when I took this role on. Community health centers represent our nation's largest primary care system. We are currently serving 52 million people across the country, 1 in 7 people, including 1 in 3 in rural America. We have over 17,000 locations, and it's a population that is of high need. 90% of the people we serve are poor. They're below 200% of the poverty level. 70% are below 100% of the poverty level. And so, the opportunity that we've been around for 60 years. We started with the war on poverty and the civil rights movement with 2 health centers, one in rural Mississippi and one in East Boston. And since then, we've grown to serve 52 million people. And we are nonpartisan, and we are fortunate to have gotten bipartisan support. The cost of community health centers across this nation is $58 billion estimated this year to serve 1 in 7 people, including 1 in 3 in rural America. We are high trust, but I would suggest on this journey of AI, we're not yet high tech. So excited for this conversation. Thank you.
Well, welcome. We're so glad that all of you are here. I'd like to start off with Dr. Anderson, if you can maybe just talk about some of the real world implementation successes and what we're seeing. It seems to have been sort of a year of artificial intelligence, right? So Can we just talk a bit about the impact that AI is having on healthcare in general before we get into maybe some of the access and utilization issues?
So for 2025, as we're coming to a close, a lot of the exciting implementations that we're seeing in CHAI center around the use of AI tools that are solving what have been for a long time enduring problems or challenges. The first and biggest one, as a physician, I'm somewhat biased to this, is the burnout challenge, an issue that so many physicians face. And this, of course, or part of the solution to this, of course, is ambient listening. I think one of the more recent surveys showed that over 70% of hospitals and health systems today leverage some kind of ambient listening technology. And we're seeing real results and benefit on the provider side in being able to better balance work-life issues. Many providers oftentimes struggle with completing their notes and find themselves, as I did, finishing your notes at 8:30 at night when you're supposed to be at home with your family. And so I think there's a lot of hope in technologies like ambient listening, addressing some of those challenges that providers have. I think we're also beginning to see some early signs of AI tools being implemented that are really beginning to address some of that supply-demand mismatch and imbalance that we've had in the space for quite some time. I'd certainly let Q speak to this more so than I, but the opportunities where I'm seeing from my perch within CHAI, where you're having health systems that are not the traditional academic medical centers, but safety net clinics, community health centers, really beginning to lean into this and find that they are able to procure and access and deploy AI tools that are demonstrating meaningful ROI and benefit to them is a really exciting thing that we're beginning to see now as we close out 2025 and look to 2026. Where do I see that evolving in the future? I think, it's just going to be a steady progression of identifying specific problems that providers and nurses and patients have and deploying AI tools to solve them. One of the biggest ones I think that we're really also beginning to see is the use of AI tools to find information, be you a provider, a nurse, or a patient. Providers, we love to use tools like Open Evidence or UpToDate or sometimes even ChatGPT. And I think there's real opportunity for providing physicians and frontline clinicians with the information that they need to deliver the best kind of care. So that's a really exciting space that we're beginning to see AI adoption across the frontline providers and, of course, patients.
Fantastic. So, Q, where do you think we stand with respect to accessing, organizations that serve all populations, accessing and utilizing AI innovations in health?
I think we're at the early stages. And so I do think when I was at HHS, and also still seeing patients at a health center at that time when we had the investment in technology and EMRs. So I'm grateful for the fact that EMRs are ubiquitous and in clinical settings across the country. But leveraging these EMRs in a way to maximize the tools of AI, I think we're at the early stages. And as I recently spoke to Dr. Oz, and he was asking about community health centers and the Rural Health Transformation Fund. One of the things I was advocating for is the importance of what Dr. Anderson, Brian just talked about, the importance of addressing the issues of pajama time. We have challenges, in that 15-minute visit. We have clinicians, many of us have experienced this in our primary care offices, where we see a clinician typing and being a data entry clerk, and the opportunity we have to make sure that ambient AI is in every exam room in a place like a community health center, a rural health clinic, a free and charitable clinic, I think is here. I do think the technology is fairly mature. And my hope is, as we look at this early chapter of AI, we will look at opportunities to support the workforce that is often getting burned out, compassion fatigued, and needing tools to preserve their time that they can spend directly with patients one-on-one, but also so they could be home with their families and not on a computer, entering data for the patients they saw that day. So I'm excited about where we are and the maturity of a lot of this technology, but our ability to scale it and spread it, especially in safety net communities like community health centers, we're still at the early stages.
Sachin, you're also working a lot with this sort of marginalized population. Do you concur with that, or see any other? Do you have any other thoughts on access and utilization of AI?
Yeah, look, I think lots of organizations are checking the box on AI. Boards are asking management teams, more than ever, to start to make an AI transformation. And so, all across the healthcare ecosystem, I think healthcare organizations are saying that they're using AI. I think the real challenge, though, is the transformation of legacy workforces, who have been used to doing things the same way for 30 years, and then you introduce AI, and you're not necessarily doing the requisite work to change the job description, change the leadership model, change the internal processes, change the expectations of what people are doing because of the new capabilities that AI is enabling. I'll tell you about a story from Scan, where we've had some ambient listening and decision support tools available to all our member service representatives. We've had those things in place for years, but when you actually look at the true level of utilization and whether member services supervisors are now using new capabilities that they have to actually supervise what's happening across literally thousands of workers at the same time, to build word clouds of what's being discussed and where the issues are and where the challenges are. They're not using those capabilities because they haven't necessarily been trained to use those capabilities. So in many ways, what I would say as a CEO of a 3,000 person organization is that, checking the box on yes, or, are we doing AI is the easy part. The hard part is actually really changing the work, fundamentally changing the work that people are doing, and actually using these new capabilities to actually change the actual operations of an organization. And again, I think that's where, frankly, the work has been more superficial than it's been deep. And that's why I say we're in the first inning of a 9-inning journey, as opposed to saying we're farther along. Lots of organizations are going to claim that they're farther along. They're going to, tout the ambient listening to the point, and those are some of the easier use cases. But I think, the truth is most customers, most patients still experience healthcare as fundamentally broken, and most people who work in healthcare still experience it as fundamentally broken. I think we'll know we're actually making a difference when people start to say, wow, my care is better. I think some people are saying my job is better. That's great. But right now, I'm still not sure we've actually made the real pivot to where, we're delivering clinical services with higher levels of reliability than we were a few years ago, absent these capabilities.
Yeah, agreed. So I think, I'd like to get into some of the real world implementation stories, right? But Brian, I just want to ask you first, what do you see as the most successful use cases right now, the ones that are working in the industry? And then conversely, what are the ones that maybe are maybe lagging behind in their success? Because to Sachin's point, everybody's talking about ambient listening and how they're using it and how much it can do. And we know it has great capabilities, but is the rubber hitting the road when it comes to implementing?
Let me just kind of riff off of what Sachin was just commenting on. I think one of the real challenges, in this space, because AI is so disruptive, is change management. How are we actually going to deploy these tools in meaningful ways and manage the people? I think, many of us have been in this space and recognize that, the technology is the easy part. It's really about the people and the change that you're navigating through, using a highly disruptive and amazing tool like AI. Can be a real challenge. And part of the challenge I've seen over and over again at so many health systems is how are you actually measuring success? Like even with ambient listening, like I think we'd all agree, wow, the penetration is amazing. Greater than 70% of hospitals are using this. You ask any 10 hospitals or health systems how they're measuring success in that, you'll get 10 different answers. And so part of, I think, the real challenge behind being able to feel that kind of improvement that Sachin is describing is we don't have consensus on really what success looks like at the other end. And so, I would say that, one of the things that we're trying to focus on in Chai is coming up with that common definition of, what does success look like at the end of this? For ambient listening, is it just reduction of pajama time? I think patients could probably care less about that. Providers would care about that, but if we're here to serve our patients, what is the real answer? And I don't know what that is yet. And so I think, to your question about, what are the really successful uses of AI? The one that I'm going to give you is probably not one that you would anticipate. It's patients using these tools themselves and then going and having really informed conversations and appropriately, I would say, challenging nurses and providers in those conversations. I think we need to do a better job of listening to our patients when they come in with, they've gone to one of the, the big frontier model developers and asked it a question and come to their provider with a really informed conversation. There are countless stories out there of patients putting in, rare signs and symptoms and coming back with a diagnosis, and lo and behold, Claude or ChatGPT or Gemini was correct. And, their life may have literally been saved. I have, several personal stories of patients who have lived longer and more complete lives with cancer because of that. I think those are some of the most powerful stories where patients are taking this tool into their own hands and using it. I think providers, and I'd use this as a challenge actually, providers and provider organizations need to do a better job of having an informed perspective on how to partner with their patients as the patients are going out into the real world and going to all these apps and websites. And we don't know how, patient specific sensitive data is being used across this ecosystem, but helping patients navigate that experience and what are the trusted resources that our patients should use. I think that's part of the challenge that many health systems candidly aren't meeting yet. And so I think it's a great opportunity that we're seeing real success with patients, but a missed opportunity on the provider side, not leaning into that space and developing, collateral and content to help educate patients on how to navigate that.
Dr. Rhee, thoughts?
I agree with what's been stated. I'm going to frame it in terms of these opportunities, in terms of how we think about the role of innovation and the role that we have to support innovation, to assure that our health centers are employers of choice, providers of choice, and partners of choice. And in my mind, the opportunities, as I was highlighting, like ambient listening, pajama time, a lot of that is related to, we have a primary care workforce crisis. We need to have tools that can help support and reduce the burnout and compassion fatigue of our extremely overwhelmed primary care workforce, especially those who are serving in these high need communities in rural America and in these in these settings where they are often going beyond the exam room, I like to say. They have to address the broader vital conditions that our patients and their families suffer from, whether it's related to transportation or food insecurity or housing, jobs, etc. So, health is so much more than healthcare, and so much of primary care is challenging because you're trying to address so many diverse issues that a patient and a family has, and you've only got those 7 or 8 minutes. So how can you use technology to support the workforce? But then, as Sachin and others were saying, and Brian, it is about the ultimate outcomes and patients feeling like this is essential for them. This is something that they could use to improve their ability to engage in shared decision making. And ultimately, the outcomes that I know when you look at the broader health system, whether you're a health plan or a provider, is actually a tool that's improving my health outcomes, and delivering that value and reducing my costs. That's going to be an essential part in their provider of choice. Now, my argument around partner of choice is I think what we have here, and part of it is because of educated by my 10 years at IBM as their chief medical officer at a time when AI was very early. And if you're a big Game of Thrones fan, for those, winter was always coming with AI. There were always AI winters that came. But winter is no longer coming in AI. It is here to stay, even though it's very cold here in Needham, Massachusetts. But ultimately, we've got to face the fact that AI is now here to stay, and it's not going to go into a winter stage. So the culture of tech and the culture of healthcare are so different. And I think that's part of the challenge we have in terms of AI in healthcare. These cultures are so different in how they approach the technology and their literacy of it and their misunderstanding of each other. And ultimately, these cultures need to mingle better and respect each other more, understand each other more, seek to understand, to be understood. But also, we have to ultimately get to the equation humans plus AI is greater than humans only in healthcare. And that is not an easy equation, especially when often, providers, healthcare providers, patients have done it a certain way without leveraging this technology. So I'm intrigued with that cross-cultural challenge that often exists with the culture of tech and the culture of healthcare. So those 3 areas, employer, provider, and partner of choice, many opportunities.
Thank you. So how do you think AI should be led in these healthcare organizations? And I heard a CEO of a major health plan last week say from a stage that it's likely that the CIO and the CHRO will be the same person in the coming years because this is so people-centric, right?
It's interesting that you say that. It's one of the reasons, we've actually placed AI as the imperative of our CHRO at SCAN. So to our knowledge, we're the only organization that's actually housing its AI initiatives with our chief people officer, because absent that kind of people transformation, you're not going to really see the kind of movement that you're really talking about. You're going to have lots of cute pet projects. You're going to have lots of check the box initiatives, but at the end of the day, you're not going to see that broader transformation that you're actually talking about. All of our learning and development efforts at SCAN have been fully reoriented around AI, recognizing this is the single most important thing for people to be learning in the workforce today. So again, I really do think whoever that CEO is pretty smart. I think they're on the right track. That said, I mean, I do worry right now because we're in this kind of phase of AI fool's gold. I mean, I can tell you, I meet about 10 companies a month, and most of us are not able to tell the gold from the coal. And I think there's going to be a lot of wasted time, working with organizations and working with startups and working with, folks who are chasing a fast buck, looking for a liquidity event, looking for their Series B, their Series C, whatever it is. And I think that there's going to be a lot of wasted effort. And that's why I really applaud, people like Brian who are trying to kind of build standards and create frameworks that allow us to make better decisions around this space. But I'm super, super worried about it because we just went through 10 years of wasted effort in digital health. I think there's a real risk that we're going to go through 10 years of wasted effort in AI as well. not to say that we're not going to eventually get there, because, we will eventually get there out of necessity. But I think one of the other bigger challenges is payment reform has been so stalled that the business model for AI is not as robust as it could be had more healthcare organizations made the shift towards value. And so, a lot of the value that you can get from AI is with more appropriate utilization, more parsimonious utilization, faster time to diagnosis. And I think, for all the reasons that health IT was under adopted for a long time until the High Tech Act put incentives in place, I'm not sure about the state of play of incentives with AI, and I'd be curious to hear what Q and Brian have to say about that. I just think we may sub-optimize this for a while, because the business case for AI, after you do away with the kind of basic use cases like ambient listening and billing and coding, the diagnostic acumen, the clinical decision support, all the other places where AI can really help make quantum leaps, feels a little bit harder to make.
Can I just jump in? Such a completely agree. I think it may be a little bit of a hyperbolic statement to make, but I've said it before. I do not believe in an AI optimized future that there is a future for fee for service. We need to make that transition to value-based care if we truly want to incentivize the use of these tools, which, one of the biggest uses and hopes is that it's going to deliver better care, because we have expert classifiers. They're going to be able to identify patients before a high cost, high acuity event takes place. In a fee for service world, there's no alignment to the provider organization to do that, right? Like, why would I want to keep people out of my emergency room? That's where all of the revenue starts and is generated. And so, I really hope, and we're beginning to see some signs with the current administration in terms of trying to align some of those incentives to outcomes and, the overall value and value-based care as we see that. I know that there's there is a rich and complicated history in the value-based care space, but if we don't pivot and move more in that direction, all AI is going to do is going to drive up the total cost of care, because AI is very good at doing certain things in parallel with incredible efficiency. And so, that's going to lead to AI physicians that are going to have, thousands of patients that are being seen at a level 4 or a level 5 visit, and things like that just drive up the cost. I don't know if you disagree, but.
No, I don't. And I was, look, I was going to bring this, because to me, the current structure is typically tech is in wherever it is in your org chart. It's typically viewed as a cost center of sorts. And I know in community health centers, we typically have a director of technology, a chief information officer, and sometimes that person sometimes it reports directly to the CEO, but often it reports to some other part of the org structure. And part of me thinks it often represents where people think, like the CFO or others, is it a cost center or is it an insight center? The potential of the technology, I hope, is it delivers insights. And the potential is that everyone feels just like, unfortunately, I bring these 2 phones with me everywhere I go. Like, I cannot leave without my AI. I need my AI to help me, do my work and make better decisions. And we're not there yet. So, how do we convert, the chief information officer from a cost center mentality to the chief insights officer? And to me, where every part of the C-suite is saying, I need these AI tools. And I do think in many ways, I appreciate how Sachin was thinking, chief people officer. I do know my former employer at IBM, they've done that, where they focus a lot of their AI efforts around, eating what they make or what they cook, and so they've done that where it plays a very important role. There's so many functions in HR that could be simplified and made more efficient through AI tools. There's one piece I want to highlight that is unique to community health centers, which speaks to the importance of patients. All community health centers, which I would argue any part of the health system can choose to do this, all community health centers are 51% patient boards. This is part of the history of our 60 years of health center, and that's what I appreciate. We've been trying to train and teach our patient governed boards in community health centers who represent the patients that they serve about this technology and governance models and such. And I do think in many ways, this helps us bring it back. We have a trust crisis in our healthcare system. And I would argue the most important stakeholder we often always forget is the patients. So we've been on this journey trying to educate our patient-governed boards and 1,512 health centers about the role of AI as it is evolving now. And to me, there are certain things that are going to be essential. It needs to be responsible, as Brian and his organization is working to advance. It has to be ethical, and it has to be transparent. And these are words that we've heard from a lot of these engagements from our patient-governed boards.
Can I just also add a comment onto that? So in Chai, one of the, I think, most important topics that all of our health systems are focused on and have been focused on for about at least the past 6 months has been this concept of AI governance queue that you brought up. There are so many success stories in that space, but also a lot of failures. I'll start with a failure. So last year, 2 of the biggest academic medical centers in the country launched an effort to stand up a robust AI governance committee and infrastructure, and they ended up spending approximately $5 million just to monitor like a dozen models. And they quickly realized this is not cost sustainable. They're going to, run their budget bankrupt if they continue to do this to expand out to, the hundreds of models that they actually have. But the success in that story wasn't the infrastructure challenges that they had. It was how they created a cross-sectional team to govern the use of AI as a tool. And I think, Sachin is hitting on that, Q, you're hitting on that. Both of these AMCs did a couple things. One, they did not vest the authority just in the CIO, which I think traditionally, like in the digital health, past several decades, we've sort of vested those decisions in the IT shop. What we're seeing now with multiple health systems is creating a level of accountability with the service line or the business unit leaders. So if it's a clinical decision tool, it's the cardiology chair or the surgery chair. If it's, an administrative tool at the front end, it's someone from the administrative department. But whoever it is, that person needs to own the tool and own the performance metrics for success or failure. But it's brought up to this cross-sectional team that I think, to Q's point, involves someone, if it's a large institution, someone from the Patient Family Advocacy Council, the PFAC group, or patient community advocates. But it also involves, AI subject matter experts. And so those can be AI engineers or just people with expertise to understand how to navigate, I think, a lot of the challenges that Sachin is describing, how to separate the coal from the gold. And one of the things that we've heard over and over again is like, we want, as part of our procurement process in these governance committees, we want to be able to, there are key things that we want to be able to hear or see from these vendors to kind of suss out, which ones are real and which ones, are fake. And so part of what we've tried to do in Chai is create these AI nutrition labels and strongly encourage health systems that if you don't know about these AI model cards, you can go check them out. But they're essentially table stakes for a lot of health systems now in the vendor community. If they want to respond to a procurement opportunity, show your model card, show the attributes. How is your model trained? What are the indications for the model's use? What are the limitations for the model's use? What is the performance of the model on specific subpopulations? Those are important questions that every AI governance committee should be asking before they make, really important decisions on which model to buy.
Sachin, thoughts on how organizations can sort of secure buy-in from the right leadership across the organization and then move forward with this?
Look, I think it's really complicated. It's going to be really specific to the individual organization and the unique business challenges. I think, there's a recent study done by Menlo Ventures that showed that healthcare is actually the industry vertical in the United States that's adopting AI the most. And I think that has a lot to do with the cost and quality challenges that we have right now. And, really, I would actually put aside the quality challenges. It's really the cost pressures that both payers and providers are facing, and the desire in some cases to substitute, labor with artificial intelligence. And you're seeing, a lot of that kind of activity. At the same time, I think the hardest challenge that most organizations are facing is how much legacy analog process we have, and how, to really do AI at scale across an enterprise, you have to build a data lake that actually enables you to be able to create all the connectivity that you're trying to create, with information. And the truth is, in most healthcare organizations, information sits in lots and lots of different places. It's much easier to wave a wand and say, we're going to pull all this data together and get X, Y, and Z insights. Much harder to actually do that. And so I think that there's, you've seen models where organizations have named a chief AI officer. That's something that we've contemplated. Someone to kind of be a center of excellence. We have someone in our organization who is kind of like the AI SME. And that person holds AI office hours, leads a lot of our AI training. And you're just trying to create some language, some familiarity with the language and some basic use cases around the organization. But I do think one of the biggest challenges, honestly, is like educating people on like what is really AI versus what is like automation that could have been done 20 years ago. And I think there's a lot of confusion going on right now on like, okay, like is optical character recognition AI? It's not. And lots of people want to kind of, say that it is. And what does it really mean to be enabled by a large language model and build agents that actually like transform your business model, right? So again, the if I had to summarize it, it's really to just get started and start making mistakes. I think that's probably the best thing you can do if you're an organization, is just start making some mistakes, because it's those mistakes that are going to inform your future strategy. One of the biggest cultural challenges we have in healthcare, though, is that we are like the most risk averse industry, and we drown everyone in regulatory tape and conservative reads of legal guidance and regulation. So even just getting started is the challenge in most organizations. So I would say, the worst thing you can do is build a plan to build a plan to build a plan, which is how most healthcare organizations do anything. And I would actually say, like, to everyone who's listening, is just get started, start making mistakes that can then kind of inform future strategy and build the intelligence around what can go wrong, what can go right, so that you can make the pivots that you need to make to actually, make forward progress.
Yeah, those measures are everything. You just said get started and make mistakes. And like 10 minutes ago, you're like, we're going to waste so much time with our mistakes. And it's so like both are true, right? Both are absolutely true. But so
both
Brian,
are true, but
measuring...
a lot of it has to do with like, and I want to make sure I qualify the first statement, which is,
yeah,
we have a nation of hucksters right now, vendors that are selling fool's gold to people. And so you make mistake on not the fool's gold is what I'm suggesting.
Yes. Okay. Perfect.
Yeah.
Yeah. I mean, we have to learn. We have to learn,
Yes.
and we can't wait to implement. We've got to move these things forward. And there are going to be a lot of lessons, just as there were, 15 years ago with the last wave of technology. But I think that's one of the beautiful things that the work that Chai is doing can bring to the industry, is to create a standard, a way to measure these things, a vetting process for organizations to try to do the best that they can.
Yeah, no, I mean, it's when we launched Chai, we did not want to be just another standards organization developing standards. Standards are important, but I think one of the challenges, and Sachin, I think, is describing it like perfectly, and many of us, I think, struggled with this as digital health tooling kind of emerged, is separating the real tools that are going to, drive ROI and, improve clinical quality versus those that are just going to be a driver of cost on your bottom line. And separating that is really challenging. And it's perhaps even more challenging in AI. So yeah, one of our core missions in Chai is not just to build the common consensus definition of what good looks like and doing that use case by use case, but what are the metrics for which we can actually hold all of us, each other, accountable to what performance and what good performance looks like. It's an interesting challenge, and I'll be transparent with you, Sandy. It's easier to get buy-in to do something like that from health systems. It's harder to get buy-in from the vendor community to do that. Now you might say like, oh, because people don't want to have their feet held to the fire, and maybe that's the reason. I think oftentimes, though, what we've heard is, the vendors, I think, appreciate that, ultimately the product that they're building is hard to encompass in just one or two metrics, right? They want to position themselves as a real partner to health systems and that value, there's some unmeasurable component of that value that you can't deduce down into a performance metric. And so that's part of the challenge that we're facing right now, is getting buy-in from the vendor community about what those performance metrics actually look like, and then working with the end users, health systems and payers, on having transparency around how these models actually perform. Because I think at the end of the day, we want to get exactly to what Sachin is kind of describing, which is the hucksters. Thank you. We don't, we'll talk to you later, but we want to really focus on working with the vendor community that's actually driving improvement in this space, reducing cost, improved clinical outcomes, better patient engagement and satisfaction.
So what recommendations do you, and I want to hear from all three of you on this, what recommendations do you have for organizations to be evaluating that and to identify the difference between the hucksters and the valuable partner? And I'll start with you, Sachin, since I picked on you earlier.
Yeah, I mean, look, I think some of it is really doing your homework. And I think, we have a lot of I know a guy behavior in healthcare. Somebody sold me something 3 years ago. I liked it. They've now changed jobs and they're now at another company and they're going to sell me the same. So, and the truth is I think I know a guy might even be a good way to do things, because if you do have somebody who's trustworthy, they are likely to be trustworthy again. At the same time, we oftentimes don't have the internal knowledge within our organizations to make smart decisions about tools and technology. So one of the things we've done is we've built an AI advisory council at Scan, which is, because we can't afford all the AI expertise internally, but we can buy a couple of hours a month, from people who really do know what they're talking about. And we bring them in to vet the tools and the technology. And those folks who do spend their lives in AI, like, can help you tell the difference between, where something is just an I know a guy, or, something is like a truly transformative, well-built, for industrial scale kind of solution. And so I think it is finding a group of experts who can help inform your diligence processes as you're onboarding these new vendors. I think another key piece of it that we learned early is to never get into a contract longer than a year.
Yes.
Lots of
Stickiness.
organizations are all about doing the, recurring ARR, 3-year, 5-year, 7-year deal. The solution you bought in year one may be obsolete by year two, and replaced by something way better by, a newer company. And so I think changing your procurement policies ends up being super, super important, to really be able to perform well. And then, being really on healthcare like, and actually managing your vendors against performance standards. And what I mean by that is we oftentimes set it and forget it. And I think in these kind of key areas, where if you've never bought AI services before, you realize your bills can be really high because you're paying by the minute or the gigabyte or whatever you're actually paying for. And so you just have to actually really think about a new approach to contracting for these solutions, so that you're not getting trapped in bad contracts from the beginning. That's a little bit of what we've learned over the last couple of years.
Yeah, I hear that one a lot. Dr. Reed, how are we calling balls and strikes? Do you have thoughts on this?
So I'll give you the concept that we're advancing at NAC, and I believe this is important for the focus on safety net communities in general. So we're interested, and part of this is my experience at CVS and knowing, we're traditionally used to like a medical formulary, a pharmacy formulary, medication formulary. And typically there are two metrics you look at in terms of what is on your formulary. You look at a combination, your clinical evidence. There's an advisory group that looks at the clinical evidence, and then there's another group that negotiates, the drug prices. And often those things have to coincide and in some ways. And then there's certain drugs that are on a formulary, and many of these formularies are based on those two metrics. And so we are interested in advancing a digital health formulary for the safety net for all. And so because we are discovering, as was shared, there are a lot of fool's gold out there. There's a lot of folks who are, the C-suite of health centers could be overwhelmed with just the whole day could be on all these folks selling AI. I think of it like my daughters when they were younger, they wanted sprinkles on their ice cream all the time. So I almost viewed it like as sprinkles. Like AI is like, oh, we have AI.
Rainbow sprinkles, Q.
Rainbow sprinkles.
For
Yeah.
the win.
So it's like
Everyone likes rainbow sprinkles.
Makes it great. So everyone's using AI in that way. Like, oh, we have AI. It's supposed to make it great. And as you know, there are a lot of things that aren't real. And I do think that's part of the culture of tech. Sometimes, you know, you fake it till you make it. And that doesn't work in healthcare, where we're often, you know, do no harm. We don't want to make those. We should be more comfortable making mistakes, but we often are not. So this idea of a digital health formulary where we could leverage the health center movement and the safety net providers, I'm hopeful that rural health clinics and critical access hospitals and other stakeholders will look to this. And we could be very transparent to say, look, this solution is meant to serve this purpose. I hope there are going to be nutrition labels and assurance labs and other ways in which we can kind of make sure that the AI is ethical, transparent, and responsible. And there's almost like a nutrition label, because we will discover there's certain solutions that were made for a certain population, maybe a part of rural America, and then you're looking at a limited English proficient population, it would not work as well and effectively. So we want to create that transparency. We want health centers to share their learnings and share their references for these AI solutions, create that kind of community of sharing and that digital health formulary. And hopefully on behalf of them, because many of these health centers cannot negotiate on their own the best price, because they represent, you know, the average health center only has a budget of $30 to $35 million and a staff of 250 and serving 25,000 patients. So we hope we could be that digital health formulary for the safety net and create that space for the determination of the coal from the gold.
And let me just pile on here, Sandy. One of the really important things that we've appreciated over the past year, 2 years, is something Sachin said, which is having contracts that have the right time duration. And it's oftentimes a year or less sometimes, like, you know, particularly in a space where AI, where it's moving so fast, you know, the technology that you buy now is going to be out of date in 6 months. And there may be a whole new approach to solving whatever the problem is you have that would involve going with a different company. And so that kind of vendor lock-in is going to be, I think, exquisitely dangerous for such a fast-moving space and soon to be very disrupted space by AI, which is healthcare. So I think, shorter-term contracts. The other thing, to separate, the gold from the coal, I'll double click on what I had said earlier. Demanding a level of transparency from the vendors to help inform your procurement decision it sounds like, from the Journal of Duh, like, of course you should do that. Part of the reason why we rolled out the model cards was to create a standard for vendors and health systems to say, like, yeah, this is the minimal set of transparency attributes that we want vendors to share. And vendors that were part of this process within Chai are comfortable with sharing that information and not revealing their IP. And so, there are key things in there that should really be informing the procurement process. Things like, how was the model trained? What were the data sets used to train the model? To Q's point, right? People that live in rural America, oftentimes their health data is not used to train AI models, right? That data set comes from highly affluent, highly educated, urban, likely coastal cities and communities. It doesn't come from middle America. And so, one of the other attributes is, how does this model perform? Has it actually been evaluated by people other than the developer, right? And this gets to a level of trust, right? So obviously, in an ideal situation, you would have an entity that can, evaluate models and issue, report cards on how these models perform. That's something I think that Q and NAC are stepping into and doing that for the safety net community clinics, right? We need organizations like that have a level of authority and competence and speak for their community to evaluate these models on behalf of their community. Because oftentimes an AI model that's trained on data that comes from, San Francisco or LA, probably not going to perform well in South Dakota in a rural community there. So demanding a level of transparency, I would urge people to consider using model cards, because that really gets to the heart of a lot of these attributes. The last thing is, when we think about, and Sachin also mentioned this, tying the vendor relationship to performance. these are tools that are rough, right? These are not highly polished, highly mature tools. We've been in this for just a number of years, and we're all learning together. If we think that the quality level of these tools is the best it's going to get, we're horribly wrong. Having a vendor that is committed with you as a health system or a payer to identify what the performance metrics are for success, and committed to also improving when, not if, it potentially falls short of those metrics in certain uses, is really important. We've found health systems challenged to get buy-in from vendors in that, and I think that's telling. If you have a vendor that's not willing to share with you the performance metrics, because oftentimes the performance that a health system sees does not include in totality all of the insights and metrics that are available as it relates to performance. So getting buy-in from the vendor to share that kind of performance, but also a commitment to remediate models where the performance is, degrading or lagging, is also really critical. So those would be some of the recommendations I'd give.
Fantastic. Well, we're about at time. I want to give you each a couple of, or just a chance to maybe give us in just a few words, where do you see AI in health in the next 3 years? So get out your crystal ball. We've talked about some of our failures and successes and where we're at right now, but where are we going to be in 3 years? Who wants to start?
I'm happy to talk. We didn't talk about this explicitly, but one of the themes we were going to explore was AI in resource poor settings. And I think one of the kind of really untold stories about AI is the way in which it really democratizes access to information and capabilities. And so I actually think AI remarkably has an opportunity to reduce healthcare disparities because of the low marginal cost of implementing it on a per person basis. And so, when you think about the information that you have at your fingertips today, that you used to literally have to buy a textbook. You were a better doctor if you bought better textbooks 30 or 40 years ago and read those textbooks. Has gone away completely. And you can download a free instance of any of your favorite AI tool and have information at your fingertips that can be used to actually save someone's life. And so I think that there is an incredible equalizing effect of AI that doesn't get talked about enough. And so I think we're going to see a lot of really positive work over the next 3 years in resource poor settings to raise the level of play and care in places that otherwise wouldn't necessarily have the resources and cost to talk about. It's the holidays. I'll end on an optimistic note. So.
Fantastic. Thank you. Q?
I'll connect the 3 words I was going to choose. Well, there's one word I want to choose first, which is the concept of tequity. That's the hope. Whether it could be achieved, how do we use technology to advance, that type of health equity in communities of highest need, especially in rural America, that would be the broader hope. But I do, connecting to some of what I'm witnessing, the Rural Health Transformation Fund, I do believe those $50 billion could play a very catalytic role in rural health opportunities. So those were the 3 words that I was going to choose in the next 3 years, right? You were talking about the next 3 years, because we are discovering with our health centers across the nation, especially in rural America, where we already serve 1 in 3. And I believe in the next 20 years, we will serve almost 100% of rural America, because I don't see another primary care solution in rural America better than community health centers. And so as I shared my conversation with Dr. Oz, he said, Q, if there's one thing you could do, what would you want? I know it's less than probably 5% of all exam rooms in community health centers, especially in rural America, have ambient AI, while some statistics in hospital settings are closer to 70%. My hope is that there's an extraordinary rural health opportunity with the Rural Health Transformation Fund. And in the next 3 years, community health centers will be at the core of leveraging that AI technology, that mature technology like ambient, like predictive AI and other technologies. So that's what I see. And I am also going to wish everyone happy holidays and appreciate the opportunity to be on this panel with all of you.
I'll give you 2 words, Sandy. AI physicians. That I think may cause a level of fear in a lot of physicians and nurses for that matter too. I think it's coming. In Chai, I can count on two hands now the number of startups that are aggressively pursuing AI physicians. And I think we're seeing in the agentic space already a level of autonomy or semi-autonomous nature to a lot of these agents that, it's naturally going to progress, in the next 2-3 years to agents, physicians, helping to manage chronic diseases, helping patients in the outpatient setting with, lower acuity events. I particularly am excited seeing that. I agree with such an NQ in lower resourced rural communities. I think that's where some of the impact is going to be felt the most. I don't see it as, displacing or, physicians and nurses losing their jobs. We can't hire ourselves out of the shortage of nurses and physicians that we have. We need these kinds of tools to help us reach the patients that don't have access to care or don't have enough access to care. And those are particularly in the rural places of our country. So I'm really excited about AI physicians.
Fantastic. Well, thank you so much, Brian, such an NQ, for this great dialogue. We really appreciate your time. I want to wish everyone here a happy holiday and just remind you all it's time to register for ViVE. If you haven't already done that, the prices do increase tomorrow. So make sure you get out there and register for ViVE, and we will see you in LA in February. Have a great day, everyone.
Bye-bye.